Hi students. Today we'll be talking about a very important MCQ. This is regarding a very important new drug which is available to all the clinicians now in our outpatients called Vaptans. And in fact, a question also came in your last year's NEET PG 2019. I'm Dr. Siddharth Sethi, your pediatrics faculty, and I'm a pediatric nephrologist by my profession. So the question which came in NEET PG was which drug is used in SIADH associated with advanced CHF. Now, first of all, taking you to a very important question for your exams, hyponatremia. Now, what is hyponatremia? Remember, all of you, hyponatremia is actually a disorder of water balance. So, it is not like sodium is less in the body. The problem is there is a relative excess of the body water as compared to the total body sodium. So there is a relative excess of the water, which is mostly because of a problem in the vasopressin hormone. Now remember students, hyponatremia is of three types: hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. Now, all of you know about hypovolemia. For example, vomiting, diarrhea, burns. Now, in all of these states, the patient has features of hypovolemia, which can also occur in cerebral salt wasting, Addison's disease, and diuretics. Now, on the other hand, what is euvolemia with hyponatremia is SIADH. So basically, there's an inappropriate ADH secretion because of which there is low sodium, so there is more water in the body, so there is a dilutional hyponatremia, and the urine sodium is high in SIADH. It can also be hypervolemic. So basically, for example, you have edema in nephrotic syndrome, CHF, liver failure, so there is hypervolemia causing hyponatremia. Now, there are many vasopressin receptors: V1A, V1B, and V2. Now, today we will concentrate on the V2 receptors which are in the collecting duct of the kidney. Remember, they are in the collecting duct of the kidney in the basolateral membrane. These receptors are responsible for insertion of the aquaporin channel so that the water is getting absorbed in your body. So I'll just show you a cartoon, and this cartoon shows that when vasopressin attaches to the vasopressin 2 receptor on the basolateral membrane. So this is the apical membrane and this is the basolateral membrane. Now in our body, when vasopressin attaches to the receptor via cyclic AME, cyclic AMP, this is very important, cyclic AMP, there is phosphorylation of the aquaporin 2 receptors, and now water is absorbed in our body via aquaporin 2 receptors on the apical membrane, and then the water is reabsorbed in our body via aquaporin 3 and 4 channels on the basolateral membrane. So remember, all of you, aquaporin 2 channels are on the apical membrane, and 3 and 4 aquaporin channels are on the basolateral membrane. Now, what Vaptans do is they competitively they bind to the vasopressin 2 receptor. Now, once the Vaptans bind to the vasopressin 2 receptor, now the synthesis of the aquaporin 2 channel is reduced and water is not absorbed, and you get a dilute urine. So remember, they are aquaretics. They are not diuretics, they are aquaretics. More water is lost from the body. Okay? More water is lost, so your serum sodium will be maintained if you have hyponatremic state. Now there are many Vaptans in the market, but I want all of you to concentrate on tolvaptan, which is a selective V2 receptor antagonist. And on the other hand, intravenous conivaptan was the one which was first available in the market. It is intravenous, and in the US, tolvaptan and conivaptan are available, In our country, tolvaptan is available. Every chemist of our country has now tolvaptan. Remember, all of them are metabolized via the liver. Now, what do they do? Basically, tolvaptan, conivaptan, they will improve the sodium, especially in euvolemic and hypervolemic hyponatremia. So please remember, all of you, Vaptans are meant for euvolemic or hypervolemic hyponatremia. Don't use them in hypovolemia. If there is diarrhea, you give normal saline. So don't use Vaptans in diarrhea or say burns or any other hypovolemic state. Now remember, if you have a serious patient who has symptoms with hyponatremia, give 3% saline. So drug of choice for symptomatic hyponatremia is 3% saline. Now if this patient is hypervolemic, we will restrict the fluids. Now if fluids are you're not able to maintain the sodium by fluid restriction, then only consider Vaptans in euvolemic or hypervolemic hyponatremia. And before going on further, all of you, I would also like you to know that cyclic AMP pathway is also used in the cyst generation in ADPKD, autosomal dominant polycystic kidney disease. So Vaptans have now also a new role in preventing new cyst formation in ADPKD in adults. So in ADPKD, autosomal dominant polycystic kidney disease in adults, we use Vaptans. Now, when should you not use Vaptans? In hypovolemia. In symptomatic, it is better to use a 3% saline. If there is, say, Addison's disease, so this is again secondary to hypovolemic hyponatremia, you should not use them. If there is an activating mutation of the receptor, then Vaptans will not act, okay, because then there is a straightaway gain of function mutation of the receptor. And since all of them are metabolized by the liver, so in liver disease, you should not use tolvaptan or conivaptan. So coming back to the question, the drug used in hypernet, hyponatremia, hypervolemic hyponatremia would be a Vaptan if fluid restriction is not helping. But remember, we should give these drugs with caution because these drugs have side effects. They increase the thirst as well. So we need to take care of the fluid intake in these patients. So they have even hepatic toxicity as well. So that was all for today. I'm Dr. Siddharth Sethi and I'm always available for pediatrics queries on the club and on Facebook. Thank you.